Good morning.
Good morning.
How's it going?
Pretty good. How are you?
Oh, not too bad, not too bad. Just put the little guy down for a nap because he was getting to that point where he was no longer compatible with being awake. Just started to throw stuff, and I'm like, really?
That's so funny. How old is he now?
It's 2 and it'll be two and 2 months.
Okay.
In a week, so we're in the terrible twos. No. It's there. He's developing opinions, and he knows how to say no now, which is awful.
Oh my gosh. I remember when my nieces were that age. It's so crazy just seeing them like become a person and be able to like now, express and make decisions, and sometimes it's great and sometimes
there are don't let me whitewash it like saying parenting is terrible. It's not. It's actually pretty awesome, but there are some moments where you just why.
That's so funny. I really enjoyed your email this morning. Thank you.
Yep. The funniest part is the only reason I happened to catch that was I was reading over the script again, and I remember there being, I think, like a bologna company out of Pennsylvania that I heard a commercial for once, and I was like, oh, they said it differently. I looked at that. I was like, I should look that up. So
how do you say it? I think I'm just gonna say New Hampshire, but
that's Lebanon, not Lebanon, Lebanon. Yeah.
That is too funny.
So what I'm gonna do is I will share our starting screen here. Get Zoom over here. So that is good. I think screen sharing, not broadcast. Okay, we're fine. Yeah, I like how they allow you to be in practice mode just to make sure that everything works here.
Yeah.
So it's not just a matter of starting up and everybody can jump on. That doesn't happen until I hit the broadcast button here. So I usually do that 5-2.
Okay, cool.
Right. Yeah, I don't have much else. I think this should go nice and smooth.
Yeah.
Got the slides in. I had to convert the intern slides to an image to paste on there, because when I tried to copy it over, the formatting was getting weird. So.
Oh, really?
Yes, I stretched it out about as much as I can. So anybody who's they're on a phone, it might be a little tricky to reach. That's actually not that bad on here, but I don't know how many.
That's good.
I don't know how many other people have a 20-inch monitor or whatever that they're looking off of. But I think I should be okay on an iPad. A phone might be a little trickier, but that's okay.
That's fine.
So.
That's awesome. Thank you.
Yep, not a problem. Not a problem. Yeah, I feel it's an awkward time right now. There's really not much else to talk about. I think we're pretty much good to go.
Yeah, no, that's okay. I think I wonder. Oh, okay. Just picking up on the chat.
Yeah, I don't know. Zoom had an update this morning. I don't know if you.
Oh, really?
Or not. It's possible. Every once in a while, when that happens, sometimes it can be a little funky if you haven't gone through it. So,
I didn't see that.
Very positive. Yet. If you can hear us, that might not be a bad thing. If you can close out of this, just open up or go into Zoom and run the quick update. It only took like a minute or two on my end. Maybe that might help. All else fails, log out and log back in. Seems to work 3/4 of the time. No. Computers. Got it. That's why we get on at 10:45, because you never know.
Sometimes if I just leave the Zoom and come back, it'll reconnect, and then for some reason it starts working.
Just gave her co-host rights too. I know she wanted that for changing, but we'll see. We got time to figure it out.
Mm-hmm.
Oh, you know what? I need to send Tam a panelist invite. I didn't even think about that.
Oh, okay. Good thinking.
All right, that's sent over to her. 10:54, but I don't know that I want to go live yet until we have some resolution over there.
Yeah, Marie Paz, can you hear us?
Hey, there we go.
Hello?
Hello, how's it
Hello.
going?
Hey, team. So it seems it's going to work out, fortunately.
Good.
I started to panic just a little bit.
Oh, no.
So, Sean, can I just really quickly practice sharing my screen and see if you guys can see it well?
Absolutely. Let me stop my share here.
Okay.
Actually, I'm going to have to, because this is a new login, I think. Let me make you co-host here.
I think I can see it. I see it here where I see share screen, so I might be able to just do it.
Well, you're co-host now, so you should be able to. Go ahead and try it.
Awesome. Let's see. Okay, so let's take a look. So you're in practice session, attend cannot join. Okay, start webinar.
Let's not start the webinar yet. Just hit the green share screen. Whoops. Oh, we're live. That's okay. 10:56. That's fine. If you want to go ahead and share, go for it. I
Share.
won't.
And let's take a look. Let me take a look. Give me just 1 second. I cannot see it well. Where are we doing? You're sharing the screen. Okay, perfect. So then let me go ahead and go to presenter view. And then I will need to backward swap it.
Yeah.
And now theoretically you should be just my slide without all my notes, correct?
Yes. It looks
Perfect.
great.
Awesome. It works. Yay.
All right. So I'll have you stop here and I will put back
Okay.
And I will put back our welcome slide. And panelists, okay. What I'm going to do, we are live. People are starting to come in. I want to get this going on Facebook Live shortly here.
Good morning to those joining us. Welcome to our Lunch and Learn. We will get started, I would say about 5 minutes. We're going to give folks some time to log in and join and enter the Zoom before we start with our presentations.
All right, we're going on Facebook Live. So that stream is up and running. So whenever you're ready, Vanessa, certainly we should give them a couple more minutes.
Okay, sounds good.
I think Tam got the link, so I'm gonna promote her from here.
Morning, Tam.
Morning, Tam.
Oh, good morning. I just got your email about our other thing. Well, Move on. Every day is a journey. To everyone on this call, every day is a journey. Sean, you look well in the scenic snow.
Yes, yes. It's more importantly, it's 71 degrees in here. So
Nice. Nice. And also, Mari, thank you so much for joining us. I'm one of the faculty for MICWA.
So just another good morning to everyone that's joining us. It's 11:01, but we're going to give folks a couple more minutes to log in and join before we get started. So thank you for joining us this morning.
I think it's good we wait another minute or two as people are starting to really trickle in now. So.
And remind me, Vanessa, I'm starting at 11:20.
Yes, yeah, about
Okay.
that time.
Perfect. 11:20 to about 12:20, correct?
Yes, that would be perfect.
Okay.
Okay, it is 5:11 and I'm going to get started. I still see we have a few people joining us and trickling in. So good morning to everyone. Thank you for joining us today for our Lunch and Learn on skincare. My name is Vanessa Rorai and I'm a coordinator for the Healthier Black Elder Center. I would like to give a brief introduction of the Healthier Black Elder Center before we get started with our presentations. So the Healthier Black Elder Center, or HBEC, is funded by the National Institute of Health, and it has been continuously funded for over 20 years. Many years ago, the National Institute of Health put out a call for action to increase the participation of minorities in research and the amount of minority scientists conducting research on minority populations. So this created various centers across the country that focuses on a particular population. Here in Michigan, it created the Michigan Center for Urban African American Aging Research, or what we call MUCWAR. MUCWAR is jointly run by Wayne State University, Michigan State University, and the University of Michigan. And the Healthier Black Elder Center is the community core of MUCWAR. The HBEC is a wonderful program that aims to address and reduce health disparities through research and education. We host various events that provide health-related education to the community with a focus on aging. We provide education on topics that range from diabetes and heart health to food safety, nutrition, creating healthy habits, brain health, and more. Typically, we hold these events in person, and we hope you're still able to enjoy our new virtual format in the meantime. To learn more about our program, you can visit our website at muckwar.org, which is M as in Mary, CUAAAR.org, or you can give us a call at our office, and our office telephone number is 313-664-2616, and I will give this information again at the end of our event today. Before we begin with the presentations, I just need to make a few housekeeping announcements. I would like to ask you to please remain muted during the event so we can hear the presentation as best as possible. This webinar is being recorded and it will be available to watch at a later time on our website. For those that are joining by computer, if you have a question for any of the speakers today, please submit your questions in the Zoom chat or in the Q&A box at any time. The Q&A button can be found at the bottom of your Zoom window. And for those joining us by telephone, if you have a question that does not get answered by the end of our program, please give us a call at the HBEC office and leave a message with your question. One of our staff will follow up with you. So to start today's program, we will have a short presentation to give an update on an outreach project that was launched at the start of the pandemic with HBEC members. Dr. Tam Perry is one of the HBEC faculty co-leaders, and myself are going to give a brief overview of the project and some of our preliminary findings. Okay. So at the start of the pandemic in April of this year, we launched the Healthier Black Elder Center telephone outreach project. And for any HB members joining us right now, you may have received a call from us as part of this project. So we created a telephone survey to survey our members to see how they are doing during this time. And the goals of our project were to decrease social isolation, to share resources, to learn how our members are getting through this time, and a way to stay in touch with our members. So we have right now about 1,200 active members in the HBEC program. And this project attempted, and is almost done, but attempting to reach all of our HB members to do a telephone survey with them. Next slide, please. So our team of callers that are part of this project is made up of our community advisory board members. We have interns that are interning for the HBEC program. We have staff from the Institute of Gerontology, and we have other Wayne State University students that have been part of this really diverse team of callers that have been reaching out to HBE members. Our callers would get a list of HB members to contact, and then at the end of each month, we get together and we have a debrief meeting. And we share what we're learning from our members, what we're hearing and experiencing during these surveys. And we're also talking about what's working, what's not working, and if there's any questions we should add to the survey or remove, and making changes based on our team of callers' feedback. Next slide, please. And Tam, feel free to jump in any point. So our survey asks HB members questions on everyday essentials, their social life, their family life, their mental health, how they're coping and getting through this time. We ask if they've learned any new skills during this time, and we ask about their access to healthcare and technology. We're also asking questions to try and see their level of loneliness and social isolation as well. So to date, we have successfully completed 521 surveys. We have attempted to reach members 1,204 times. So we have been making many calls. And we have 2 publications so far based on this project. So HBC is always really important for us to disseminate research results and bring it back to the community. And so far we've done it in 2 ways. We had one of our intern students, Ayana, work on creating a fact sheet for AARP. So she created a 1-page fact sheet that just highlights some key preliminary findings of what we've learned so far in these surveys. And then we've also published a letter to the editor in the Journal of Gerontological Social Work to share, why we're doing this project, how we're doing it with the larger academic community. And it was really important to us at the start of this project to be able to capture and share both positive and negative experiences of our HB members. So we want to share the coping, the resiliency, the strengths that our members are experiencing this time, as well as the challenges, needs, and difficulties during this time. So it's important us to balance both sides of the situation. Next slide. So what have we found so far? Well, we've found that almost all HB members that we asked are wearing a mask all the time when they leave their home. So it was almost at 100%. And when we asked them, what is the biggest strength that has helped them get through this time? The most common answer is faith and prayer. When we asked if they've learned any new skills, the most common learned new skill is Zoom, which I think is great. And the second most common was returning to previous hobbies. So not necessarily learning a new skill, but going back to previous hobbies that they haven't done for a while. And that would be like knitting, coloring, and cooking. We ask members to rate how stressful the situation of the pandemic is for them. The most common answer is somewhat stressful. And the second most common answer was no stress at all. As I mentioned, we are asking in the survey if they have any needs, any unmet needs, challenges, and as a result, we have shared over 80 resources to try and address that challenge or unmet need. The most common resource information we've been sharing is for mental health services. We've also provided some HBE members with face masks. And a lot of our members have also asked for financial education support resources and food delivery services. And we also decided that at the end of each month, we would do a drawing for 2 gift card winners among those that completed the telephone survey during that month. And so far, we have mailed Visa gift cards to 14 winners so far. So those are our preliminary results that we've found. We are almost at the end of the project. We have just a few more individuals to try and reach, and then we will be able to really go through the results and analyze what we've found. Tam, any thoughts or closing comments you'd like to make?
Yeah, I'm happy to. We'll have a slide about the next step of our party line in a minute, right?
and we'll share that at the end of the event today.
All right. Well, I guess I'll just point everyone to it right now. So we are so delighted that we've been able to call so many of our members and stay in touch. I think in a lot of ways at MICWAR or HPAC, we feel like so much of our member interaction has been through our lunch and learns, but in a pandemic, you know, if there's anything Detroiters knew early on is the fierce urgency of now. And so it seemed very important to make sure that the older adult members we're in touch with knew that we were thinking about them during the pandemic. Second, and we are still thinking about you. Second of all, we realize we can't keep calling everyone individually. I know of also no other program across the country that's done what we've done. So in the circles I am in academia. So I think it's a really great tribute to research institutions getting very involved. So we are going to start a weekly social group. It's going to be on Tuesday. Yeah, oh great. We'll talk about it now and we'll talk about it later. So it's going to be Tuesdays at 1 o'clock. We're going to do one on Tuesday, December 15th. There's a typo there. So our next one is next Tuesday, December 15th. And then we're going to take a holiday break. And every Tuesday from January to April 20th, we are going to just call in for a few minutes. We're going to keep it upbeat and light, etc. But we realize that so many people need to feel connected in the world during this time. And so this is sort of the second wave of our programming for our PRP members. But I'm going to tell you this, it's open to anyone in the city of Detroit. So they can be in touch with our PRP and members, our CAB members. They can certainly contact Vanessa for more information. There are 2 student interns that they can also contact about this. But this will also be circulated to other groups in Detroit, including Detroit Area Agency on Aging, Stephanie Chang's office, etc. So we just want to make this a very nice social time for any older Detroiter. So I'll leave it at that. You'll hear more about it at the end, so stay tuned. But I just wanted to point that to people. And I hope everyone stays well in this holiday season.
Perfect. Thanks so much, Tam. Okay. So now we're going to switch over to our main presentation. And today our speaker is Dr. Marie Paz Castanedo Tardan. And I hope I pronounced that correctly.
You did beautifully, Vanessa.
Oh. Dr. Castanedo Tardan is an assistant professor of dermatology at the University of Michigan. She completed her internship and dermatology residency training at Dartmouth-Hitchcock Medical Center in New Hampshire. In 2015, she joined the clinical faculty of the University of Michigan Department of Dermatology. She is a board-certified dermatologist with interest and expertise in contact dermatitis, which is skin reactions that occur when the skin comes in contact with a certain substance. So, thank you, and please welcome Dr. Castanedo Tardan.
Thank you so much, everyone, for inviting me to speak today. I'm very honored and I'm very excited to be here. I put together a presentation from you that I did, from the bottom of my heart. I put a lot of time and effort into it, hoping that it's going to be something that is going to be useful. Please go ahead and bring up any questions to Vanessa via the Q&A or the chat, as she mentioned before. We will do all of our best to try to answer some of those questions and our concerns. Please do know, of course, I will talk about that as part of my presentation. Dermatology is incredibly broad. So, between the team and myself, we selected some subjects which we thought would be relevant and interest for you. But nonetheless, please do know that unfortunately, we might not be able to cover everything, but you never know. Maybe we'll be able to do it again. So I'm going to go ahead and start by sharing my screen. So I can go ahead and start our presentation here. Okay. Vanessa, can you just please confirm that you're seeing my slides correctly? Wonderful. Thank you so much. So again, my name is Paz Castanedo. As Vanessa very kindly introduced me, I'm one of the assistant professors of dermatology at University of Michigan. And I'm going to be talking today about African-American skin health. We're going to talk about some information, and we're going to talk about also some needs that hopefully, have been identified based on that information, and then some recommendations that we can talk about. So I would like to start by talking a little bit about our skin, start talking a little bit about the structure and function of our skin. And well, it's interesting and important for all of us to remember that the skin is actually the largest organ in our body. It occupies an area of about like 1.5 to 2 meters, if you think in centimeters like myself, but about 16 to 21 feet, which is a really big area. It has very different thicknesses depending on the location of the body. So for example, some of the thinnest skin is going to include sites like the eyelids. When you obtain a biopsy of the eyelids, there's only a few skin cells that are going to make that thickness of our eyelid, while the thickest areas, for example, are going to include sites like the palms and the soles, which have about maybe 30 cells in thickness. Our skin also weighs a good amount. It weighs about 16% of our total body weight. So it can reach about maybe 44 pounds in adults. So again, it's a very, very, very big organ. And as I show here on the drawing, there's a few things that are important to remember about the skin, which is also the fact that, of course, our skin is going to also be the home of our hair, is going to be also the home of our nails, is also going to be home of our sweat glands, et cetera, et cetera. So there's definitely a lot of different functions that the skin is going to have. When we get into more details about the layers of the skin, we think about the skin as being divided into three main layers. The first one is going to be the epidermis, and you can see that right at the top. So that is what we call the epidermis, tends to be quite thin. Then we have the dermis, which is where we're going to have, again, our hair follicles, where we're going to be able to have also our sweat glands, a lot of our blood vessels, and then finally our subcutaneous fat, which is going to be, again, that fat layer that is going to be underneath our dermis. This is the way that the skin will look like if you obtain a biopsy. There's going to be, again, the epidermis. Please do note that basket weave appearance of the outermost layer of the epidermis that is called the stratum corneum, which is part of the epidermis and is going to be something that we'll be talking a little bit about because it has some impact on our health. And then again, we talked about the epidermis, which is, again, this compact layer of cells. Then the dermis, and then finally, this particular picture doesn't show you the fat cells, but those would be at the bottom. So let's talk a little bit about the epidermis itself. Well, the epidermis, which again is going to be that outermost layer of the skin, is going to act as a permeable barrier. So we're starting to talk a little bit already about what does our skin does for ourselves. And it's made out of keratinocytes. So those keratinocytes are the building blocks of our skin. And I like to think about them as bricks. And those bricks are going to be layered in multiple layers of the epidermis. And by doing that, they are going to form this very complex structure that is going to be designated to protect our skin from the environment. In other words, it's going to basically build a brick wall that is going to protect us against the environment. So again, those keratinocytes, one on top of the other, on top of the other, on top of the other, from the basal cell to the spinous cell to the stratum granulosum, and then finally the stratum corneum, which are the names of the epidermis, are going to form, again, this nice brick wall of cells. That being said, in between the cells, there are some other important cells, which are our melanocytes. So I want to draw your attention to the picture that I have on the right. As you can see, there is those keratinocytes, which again, I want you to think about them as those building blocks, as those bricks, right? But then I want to point your attention to that cell that is called a melanocyte. As you can see, it's a darker skin cell, okay? And they are located on the basal layer of the epidermis. They are not very prominent on your skin. There's about 1 melanocyte for 10 keratinocytes. And what they do, and these are incredibly important, is that they are going to produce melanin in the melanosome. So one thing that I hope that you can see from my drawing is that those melanocytes are dendritic cells. So as you can see, they have basically branches as a tree and or arms, right? And then those little arms are the ones that are going to transfer the melanin in these little granules that are called the melanosomes, and they are going to share the melanin to our adjacent keratinocytes. So again, that's the way that they are going to transfer color to our adjacent skin block cells. One thing that is very important to remember, and that is unfortunately not known by a lot of people, is that our number of melanocytes is the same in all our races. So it really doesn't matter the color of our skin, our number of melanocytes is exceedingly similar. Where things change a little bit is when we are talking about the amount of melanin that is produced by those same number of melanocytes. So we know that in dark-skinned people, those melanocytes produce more melanin, and then melanin is also going to be distributed all throughout those layers of the first layer of the skin that is called the epidermis, while white-skinned individuals are going to have less amount of melanin that are going to be mainly limited to the basal layer. So let me show you, and of course, the reason why it's so important to talk about melanin, right, is because melanin is going to protect our skin from sun damage or photo damage. Let me show you another example of, again, how things are going to be different between darker skin and lighter skin. So again, this, of course, a drawing is not real skin, right? But as you can see, what we're trying to depict on this picture is that you have the same amount of melanocytes on darker skin versus lighter skin, right? However, the skin that is darker, and you can see that at the top, right? The skin that is actually seen as darker is going to have more melanin, and it's going to be that melanin distributed all around the cells, while the lighter skin phenotype patients are going to have less melanin, and for the most part, those melanosomes or those melanin granules are going to be limited to the bottom of our skin. So as I mentioned before, our skin has multiple functions, right? And our intact skin is actually essential for life. And one thing that is important to keep in mind when we talk about it is that, for example, when somebody has a serious burn, unfortunately, let's say a serious burn where it involves approximately, let's say, 40% of your body surface area, and the patient is a patient that might be under 70s or so, that burn has a mortality rate of about 94%. So that is a good example to illustrate how important it is for us to have intact skin for us to be able to live. As I mentioned before, and that's the reason why I added again that brick of walls for you to remember, our skin is going to do this barrier function that is going to protect us against physical, thermal, chemical injury. Of course, it's also going to protect us against microbial attack from bacteria, from viruses, from funguses. It's also going to help us regulate our body temperature, and it's going to do that by also using, for example, our sweat glands. It's going to help us in the synthesis of vitamin D. And then the other thing that is interesting and I think important to remember about the skin is that it's a very important piece of who we are in terms of our identity, our personality, and even our communicational skills, right? Our skin is the one that allows us to, for example, communicate our emotional state by doing facial expressions, or maybe when we get goosebumps, that's another reflection of how we're feeling, and our skin is going to be the one that is going to help us express that. So when we talk about skin of color, which sometimes we call also melanin-rich skin, there's definitely a lot of advantages to melanin-rich skin, but unfortunately, there are also certain disadvantages. So when we talk about, for example, the advantages of melanin-rich skin or patients with skin of color, we know that people with white skin are going to be particularly prone to conditions that are going to be related to excessive sun exposure or excessive ultraviolet radiation, because their skin gives an inadequate natural protection. So because of that, those patients with lighter skin phenotypes are going to be more prone to photoaging or photo damage, as well as also skin malignancies. On the other hand, again, those patients with skin of color are going to have enhanced photoprotection because, again, their melanin is helping to protect against the UV radiation from the sun. Because of that, they are going to age much better, and overall the photoaging is minimized in patients that have darker skin types. And then fourthly, also there is a decrease in the frequency of skin cancers. That being said, we'll be talking about skin cancers even when you're like, well, but if the number is lower, why do we need to talk about skin cancer? And there's a very important thing why we need to talk about skin cancer, which we'll talk about in a second. Some of the disadvantage of melanin-rich skin or the patients of skin of color is that they are going to be more prone to disorders of pigmentation. By disorders of pigmentation, I mean any disorders that are going to translate into darker skin, which we call hyperpigmentation, or lighter skin, which we call hypopigmentation. And one of those examples would be, for example, vitiligo. Also, because those disorders of pigmentations tend to be much more prominent on patients with skin of color, then unfortunately also they tend to have a much more severe impact on the quality of life of those patients. Patients with skin of color are also known to suffer from more scarring hair loss processes. And unfortunately also they tend to be more prone to developing hypertrophic scars as well as keloid scars. Hypertrophic scars and keloid scar are within a spectrum, and I'll show you some examples in 1 second. So on my next slide, I want to show you, and again, emphasize some of these, basically advantages and disadvantages. So this is a picture that I really like. It's a picture from the New England Journal of Medicine. It's one of our main journals in medicine, and it portrays a patient that is actually also a truck driver. So this patient that is a truck driver, if you're an astute observer, you're going to see that if you draw a line right through the middle of his face, you're going to notice, right, that the left side of his face, right, the one that is closer to the midline on my slide, is way more photo damage. There's a lot of wrinkles, there's discoloration, there's skin sagging. And on the other side, the right side of his face is actually in much better shape. This is exactly the same patient. So really the key part of this is that, again, the patient is a truck driver. So therefore, he has been driving all his life, getting all that sun exposure on the left side of his face, causing a lot of photo damage. This is another example of a patient with a lighter skin phenotype, where again, you can see some of those signs of sun damage with deep wrinkling, with deep discoloration, dilated pores, the development of some benign skin lesions, and even you can see some scars from the development of skin cancer, which is the next slide I'm going to show you here. Here we have a patient that unfortunately after many years of sun exposure has developed this basal cell carcinoma, which is this shiny bump on their lower eyelid, which is a type of skin cancer, which we'll be talking a little bit more about. So again, fortunately, patients that have skin of color are going to be less prone to all of these things that I were talking about. Some of the quote unquote disadvantages are that, again, we see patients with skin of color suffering more pigmentary disorders. This is an example of vitiligo. Vitiligo is a disorder of the skin where, for reasons that we don't understand very well, our own immune system starts identifying those melanocytes, which now you know what they are, these nice dendritic cells that give pigment to our skin. They start identifying those melanocytes as foreign. And because they think that they don't belong to our skin, then they mount an inflammatory reaction and starts attacking our own melanocyte and melanin producing cells. And that unfortunately is going to translate into the skin losing its pigment. As you can imagine, for patients that have darker skin phenotypes, it can have, for some patients, a pretty dramatic impact in their quality of life. Patients with skin of color also have a tendency to develop more scarring alopecias. Alopecia is a medical term for hair loss. And every single patient, every single population have a risk for hair loss. However, patients with skin of color have a higher risk for types of hair loss that are associated with scarring. In other words, where there's so much inflammation that hair follicle becomes basically eliminated by the scar that is going to form around the hair follicle, shutting down that hair follicle. That unfortunately makes these scarring hair processes much more difficult to treat than, let's say, the hair processes where we also have hair thinning or hair loss, but we don't have that scar that is, again, unfortunately eliminating the hair follicle. And then finally, patients with skin of color have also a higher risk for thick scars. Thick scars are in a spectrum of what we call hypertrophic scars and keloid scars. The difference between a hypertrophic and a keloid, is a little bit semantic. It usually has to do with a hypertrophic scar staying within the site of injury versus a hypertrophic scar that goes beyond the site of injury. And that would be, for example, what I'm showing right here on the picture of the right, where we have a young patient that unfortunately developed these thick scars after injury to hair earlobes or to his earlobes, likely secondary to ear piercing. So going on our subject, how does our skin changes as we age? Well, our skin, as any other organ, is going to change dramatically as we age. So let's go ahead and talk a little bit about how does our skin change. So, well, first of all, it's important to keep in mind that there are two types of aging processes. The first one is going to be our intrinsic, in other words, our chronological aging processes. In other words, the one that we cannot do anything about because none of us can, fight time and can beat the passing of time. However, it's important to remember that because of that, this intrinsic aging process is going to affect the entirety of our body, including sun protected sites. So sites that never seen the sun are still going to develop this intrinsic skin aging. And of course, because of that, it's going to really affect everybody, regardless of their skin type. On the other hand, what we call the extrinsic skin aging is going to be induced by external factors. Those external factors include chronic ultraviolet radiation. We're going to be talking a lot about UV today, and also things like smoking. This is going to usually affect people who are chronically affected or chronically exposed to sunlight. And this, when we actually see that and when we see the manifestation of that, we call that sun damage or photo damage or photoaging. And of course, as we showed on the other picture, right, those features of photoaging are going to include roughness, wrinkles, discoloration, dilated pores, dilated vessels, and of course, the development of a lot of benign skin lesions, like, for example, those things that we call sometimes sunspots, as we show here in this picture. So the people who are going to be typically more affected by photoaging are going to be those that have lighter skin phenotypes. In other words, those patients that are going to have red or blonde hair, blue or green eyes. Also, patients that live in the tropics or that live in high altitudes are going to suffer from more photo damage. Patients that work outdoors or spend a long periods outdoors for recreation, swimming, boating. Patients that have been exposed to artificial forms of ultraviolet radiation. And a very important one of those to consider is indoor tanning. And then, as we discussed briefly, and we'll talk a little bit more, also patients with tobacco smoking. So how does ultraviolet radiation actually cause skin aging? Why does the rays of the sun cause our skin to look older? Well, in this picture that I'm showing you on the left, I'm showing you the skin of a younger patient and then the skin of an older patient. One thing that you're going to see is that right from the get-go, the epidermis, the outermost layer of the skin, is becoming thinner, right? And is becoming more wavy and a little bit more undulated. The other thing, and that is usually going to be secondary to alterations on the DNA of the skin cells. The other thing that is going to happen with ultraviolet radiation is that it's actually going to break down the things that make our dermis. So as you remember from the previous slides, our dermis is that mid layer of our skin, and that mid layer of our skin is going to be composed from elastic fibers and collagen. Elastic fibers and collagen is what makes our skin bouncy. It's what makes our skin, when we press on it, for it to bounce back and snap back. When we get exposed chronically to sun exposure, the collagen fibers become thin, as you can see on that drawing, and then also the elastic fibers start breaking down. Smoking and nutrition are also going to have important factors on how we age. Smoking, as you can imagine, exposes our skin to several damaging factors. Nicotine, for example, is going to narrow the blood vessels, it's going to reduce the blood flow, and because of that, it's going to reduce the amount of oxygen as well as nutrients that are going to reach the cells of our skin. Many other chemicals that are also present in tobacco smoke are known to degrade those bouncing substances of collagen and elastin, and then again, of course, translating to thinner skin. And then the heat from burning cigarettes, as well as the facial muscles that we actually use to smoke, is going to contribute to wrinkles around of our mouth. When we talk about nutrition, we also know that nutrition has an effect on extrinsic aging. So on a nutritional study where they recruit people from Greece, from Australia, from Sweden, what they saw is that patients that were more resistant to this phenomenon of photoaging were the ones that had a higher intake of vegetables, olive oil, fish, and legumes, such as chickpeas, beans, peas, and lentils, and those that will have a lower intake of things like margarine, sugar, and dairy products. And one thing that we're getting to know more and more also is that high sugar intake has been associated with an increased risk of wrinkles as well as skin thinning. So definitely our nutrition is going to have an impact on how we age. So therefore, how are we going to be able to protect our skin from aging? Well, again, as we talked about, intrinsic aging is going to be inevitable, right? However, we can avoid extrinsic skin aging by minimizing the UV rays, right? By protecting ourselves from the sun, by not smoking, right? By eating a healthy diet with fruit and vegetables, and also by exercising. Exercising has also been shown to overall increase and improve the way that we age, including our skin. So our skin is not going to be the exception of the rule. So that is when we talk about more about skin aging, which some people might consider quote unquote more cosmetic. So when we get more into, again, more of the functional nature of skin aging and what happens as we age, there are other things to consider. So other changes that we see on our skin, mainly in our 60s, on our 70s, is that our skin becomes much drier. As we mentioned before, the skin becomes thinner. And again, that has to do with the collagen and the elastin. And of course, unfortunately, sometimes the skin can become almost paper thin. When skin becomes dry, it becomes itchy. And also, as we mentioned before, the skin can develop more age spots, more wrinkles, more creases, might appear more blotchy. Other thing that can happen, unfortunately, as our skin ages later in life, our skin becomes much more easily irritated, more susceptible for skin infection. It bruises more easily. And again, that has to do with the fact that we don't have enough cushion. So our blood vessels are floating around without that cushion that a healthy dermis used to give us when we were in our 20s. Sweating also decreases as we age, and overall our healing is going to be slower. One thing that is incredibly important, and that I'm going to spend some time talking about aging and skin, is actually dryness. Dryness might sound like something very vain and not important. However, it is incredibly important for the health of our skin. So one of the most important functions of our skin is to retain water, right? We talk about how our skin is this barrier that is going to protect us from all those things that are going to try to attack us from the outside in. But the other thing that the skin is going to do is that it's also going to be a barrier that is not going to allow moisture, water, and hydration to escape out into the environment. One of the ways that the skin does that is by a very complex composition of lipids, which are also called fats, which are going to be in between the skin cells. This is a picture that is quite elaborated, but I want to show you this picture again on the right that has kind of like, again, like that zoom view of that stratum corneum, in other words, of that layer of the skin, that top layer of the skin, where you can see those lipids or those fats basically in between those skin cells, right? So that composition of the skin cells intermixed with fat are going to make something that we call our water barrier, right? And our water barrier, for the most part, our epidermal water barrier is going to be able to repair itself. But unfortunately, as we age, the rate of the repair and also the function of the epidermal barrier is going to be reduced. Hence, we're going to lose a lot of moisture. Hence, cirrhosis, which is the medical term for dry skin, is without any question the most common skin concern in any patient that is older than 65. And it's going to affect about 50% of those patients ages 65 or older. So of all the skin concerns that we see in patients older than 65, the most common one is going to be dryness. So how can we fight dryness? And dryness that is also, as I mentioned before, that is going to translate into a very uncomfortable itching. Fortunately, some very simple skin changing to our bathing routine can reduce and in the best cases, even alleviate that dry, itchy skin. And then again, hopefully to prevent the dry, itchy skin from becoming a serious problem that put patients into a lot of discomfort. So here are some of the things that you can do, based on dermatological recommendations. One of the most important ones is stop using harsh or antibacterial soaps. I know that we have these, feeling that we need to clean ourselves really thoroughly, and this feeling that we should be scrubbing ourselves raw, and this feeling that we should be using antibacterial soaps to make sure that we don't get any skin infections. But in reality, we know that those antibacterial soaps tend to be very harsh and very drying. So ideally, it would be better to replace them with a more gentle, a more creamy, and ideally a fragrance-free cleanser. Another thing that is going to be important and very simple to change is that we should change the hot for warm water. A lot of people actually feel relief by getting into a hot shower. Like the hot shower actually kind of like saturates those skin receptors and initially help you with the itch, but overall it's going to dry your skin tremendously. It strips the skin from its natural oils, which again is going to translate into skin dryness. The other thing is try to avoid buff puffs, bath brushes, or anything that is going to irritate your skin. Try to replace for soft cloths to wash your skin gently. And then the other incredibly important thing is that you need to moisturize. There is really no way around moisturizing. Unfortunately, I think personally that it is a habit, and it's likely a habit that we built or we didn't build when we were younger. But nevertheless, it's never too late to start a habit. And the best way to moisturize is right after the shower or the bath. So when you come out of the shower, what we recommend is for you to pat your skin gently, but kind of like leave a little bit of water on your skin, because having some water on your skin when you apply your moisturizer is actually going to help hydrate your skin. And then you basically need to, quote unquote, then seal that moisture that you have on your skin by applying a heavy, creamy blend, meaning not a lot of ingredients, not a lot of dyes, ideally fragrance-free moisturizers, and again, ideally within 3 minutes of bathing. So this habit of moisturization should be done right after we come out of the shower or the bath, and therefore still in our bathroom. And then, of course, it's perfectly fine to apply moisturizers as many times as we need during the day. Other thing that's important to remember with moisturizers is that the heavier, the messier, the better. Meaning that ointments, in other words, greasy moisturizers, like for example, Vaseline or 100% pure petroleum jelly, are going to be better than creams, which are thick and usually come in a tub, and are going to be better than lotions, which are thinner and usually come in a pump. Other skincare recommendations that are important for you to consider, when you talk to me as a dermatologist, things that I would like for you to pay attention would be for you to wear gloves. our hands get beaten up so badly by anything that we do around the house. All of our household chores beat up our hands tremendously. Also, taking care of young children, has a really bad impact on the health of our skin. I have 2 young kids at home, and yep, all those diaper changes and all that washing and all that bathing can really take a toll on the health of your skin. And then, of course, gardening as well. If people have, that nice hobby of gardening, it's going to be important to wear gloves. Those gloves are going to hopefully prevent your skin from exposing to things like harsh chemicals, sunlight, and even water. Frequent water on your hands, what we call frequent wet work, can definitely irritate the skin tremendously. Protect your skin from the sun. More to come. We'll be talking a little bit more about that. And again, if possible, if you can choose something, try to go fragrance-free. Perfumes, colognes, and other fragrances within skincare products tend to irritate the skin. So therefore, the blander the personal care product, usually the better. And when we talk about mainly their moisturizer, mainly your soap. It's exceedingly difficult to find shampoos, for example, that are going to be fragrance-free, and that tends to be usually unnecessary. But moisturizer soaps are a very good alternative to consider to decrease irritation. Another thing that we should consider, especially as we get older and as our legs tend to swell at the end of the day, is to wear compression stockings. If you're noticing swelling on your lower extremities, if you're noticing swelling on your legs, it's going to be important for you to talk to your primary care doctor to see if you can be fitted, or even if you are, eligible to just buying some over-the-counter compression stockings. The swelling that happens as we age on the skin, on our legs, is going to have a negative impact on the health of the skin of our legs, and is likely going to translate also in itchy red rashes. And then, of course, see a dermatologist for any skin concerns, or if you need a skin exam because you have any concern in skin findings, and we'll talk a little bit more about that. I didn't want to leave our gentleman behind. So for the most part, right, when it comes to skincare, men have traditionally, quote unquote, kept it simple, right? However, nowadays, men are tending to be more aware about their skincare needs. They are trying to pursue healthier looking skin. And because of that, they are making a greater effort to make good decision when it comes time to take care of the largest organ of our body. So although there are certain differences in the skin between men and women, and for example, one of them is that overall the skin of men tends to be a little bit thicker than the skin of women, the basic elements of an effective skincare remain for the most part the same. So what we talked about short baths, about bland soaps, about moisturizers is going to apply for both. The other thing is, of course, that is going to be more unique for men that are shaving their faces is going to be how to improve your shaving technique. For example, if you're often experiencing razor bumps or razor burns, or you're developing a lot of ingrown hairs, try to see if changing to a single or double bladed razor instead might be actually better. Sometimes what happens is that those razors that have like a lot of different blades actually shave a little bit too closely. In other words, they work a little bit too well, and by that they can cause irritation. Other thing that is important is to change the habit of totting the skin while shaving. It's important that before you shave, you wet your skin and your hair to try to soften it. So for example, a moist washcloth with warm water can do that. It's important to try to do and to use a shaving cream. So don't go without using a shaving cream, and try to also shave in the direction of the hair growth. That also might be a very big difference to how you were taught to shave, but nonetheless, shaving against the grain of the hair is going to predispose to more ingrown hairs. It's going to be important to rinse after each swipe that you do with your shaving blade. And then, of course, that you're going to change your shaving blade frequently after about 5 to 7 shavings to minimize the irritation. Moisturizers are also for gentlemen. Make sure that you're moisturizing. That's going to trap the water. It's going to help reduce the appearance of lines, wrinkles, and of course, dryness. And then we'll talk about sunscreen, which is going to be important to wear when we're outdoors. Okay. Other question that was brought up to me when we talked about the specific things to consider when we're talking about patients with skin of color is the subject of how common is skin cancer among African Americans. So this is actually a very interesting subject. And the reason why it's so important to keep it in mind is because skin cancer as a whole is the most it is most malignancy in the United States. In other words, there's more skin cancer than breast cancer, more skin cancer than prostate cancer, more skin cancer that lung cancer. So it is without any question the most common cancer in the United States. And 1 in 5 Americans is going to develop skin cancer at some point in their lifetime. The other thing that is extremely important to keep in mind and why we're talking about this today is because anyone can get skin cancer regardless of the skin color. And one thing that is very important to remember, because I don't want to scare anybody, is that skin cancer, even the most serious ones, are highly, highly curable as long as they are detected early. So skin cancer is less common in Americans. Let's talk a little bit about on patients with dark skin phenotype. So let's talk a little bit about that. So we talked about how it's the most common types of skin cancer. However, again, its incidence is going to be different depending on the race of the individual. So for example, it's about 35 to 45% of all cancers in Caucasian. It's about 4 to 5% to all cancers in Hispanics, and only about 1 to 4% of all cancers in African Americans. So again, you're going to be like, okay, so if this is so uncommon, why are we talking about it? Well, the reason why we're talking about it is because although they are less frequent, unfortunately, skin cancer is without any question associated with greater morbidity and greater mortality when we compare it with our light-skinned individuals. Therefore, it's super important for people of all races to be aware of the risk of both melanoma as well as other more common forms of skin cancers, which we usually term the non-melanoma skin cancers. And we'll go over some of these together. So let's talk about melanoma. So let's talk about melanoma first, because of course, melanoma is unfortunately the deadliest type of skin cancer. Darker skinned people have a relatively low of melanoma compared with white skinned people, and African Americans have an incidence of about 1 in 100,000. So you might think this might not happen to me, but nonetheless, again, really what I want to make sure that we take this home message for is that unfortunately, even when infrequent, it carries a poor prognosis. So again, although it is uncommon, Black and Hispanics are more often diagnosed with more advanced melanomas. And because of that, you're going to have higher mortality rates than whites. So I started talking about skin cancer, talking about how early detection is key. And early detection is everything when we talk about skin cancer. Unfortunately, early detection of melanoma, which therefore is going to translate into a much better prognosis, occurs in about 91% of Caucasian. So 91% of patients with melanoma that are Caucasian are going to do overall well. Only about 74% of Hispanics. And then this number that absolutely breaks my heart, which is 48% of African Americans. That means that 52% of African Americans that develop melanoma are diagnosed at an older or more advanced stage and therefore are going to have a worse prognosis. So let's talk about this poor prognosis on melanoma because it is really, really disturbing, right? So again, Black people are 4 times more likely to be diagnosed with an advanced stage of melanoma and tend to die at a rate of 1.5 times more than white people with the similar diagnosis, which is, by the way, much more common in white individuals. So why might be the case? Like, why is this happening? Well, late-stage diagnosis and worse prognosis might be attributed to several factors. Some of them include less access to health insurance, also maybe a delay in seeking treatment, unfortunately also less awareness of the risk or of the symptoms, hence why I'm here today, and then less sun safety behavior, hence why I'm here again today. So there was an interesting study published recently that was titled "The Perception of Skin Cancer Risk by Those with ethnic skin. And what they did is that they interviewed 100 subjects of either African American or Asian or Hispanic descent. And what they did was basically this in-clinic survey that asked them about their weekly sun exposure, but also their sun protective practices. And one thing that is shocking about it is that 43% of people reported that yes, absolutely, they were able to sunburn. But unfortunately, only 35% thought that they might have some sort of increased risk or that may actually have any perceived risk of developing skin cancer. So in other words, there's this pretty significant subset of patients that although they are able to burn, still believe that they are not at risk of developing skin cancer. So going back to melanoma more specifically, right? What causes melanoma? Well, we know that in whites, increased sun exposure to that ultraviolet radiation, including the use of tanning beds, is a very dramatic and significant risk factor for melanoma. In the other hand, on people of color, the UV rays could definitely be playing a role, but also, right, there are other things that are going to be important. Like, for example, again, 90% of skin cancers specifically melanoma in whites are going to be secondary to sun exposure. In contrast, nearly 75% of melanomas in patients with skin of color are going to be located, for example, in the palms, in the soles, in mucosal sites like the mouth or genitals, or underneath the nail. In other words, in areas that have never seen the sun or that have seen the sun very little, right? So again, unfortunately, because of that, there's certain additional reported risk factors for melanoma among people of color, which include radiation therapy, pre-existing pigmented lesion, burn scars, a depressed immune system, or albinism. So how do I know if I have melanoma? Well, any suspicious changing or new molar freckle anywhere on your skin should be evaluated by a dermatologist. But one easy way to remember are what we call the ABCDEs of melanoma, which I'm showing right here on the picture on the right. So when you're evaluating a pigmented, in other words, a brown, a dark lesion, it's going to be important to keep in mind the A, which stands for asymmetry. If you fold the lesion in half, the left, the right need to look the same. The top, the bottom need to look the same. B stands for borders. If you can draw a nice circle around the lesion, if you can draw a nice ellipse around the lesion, those are reassuring features. However, if the borders are jagged and they look like the coast of Maine, we're in trouble. C stands for color. We like moles or lesions that are evenly pigmented, either all dark brown or light brown, but all the same color. In the other hand, as you can see the picture on the right, there's a little bit of brown and a little bit of black and a little bit of blue and a little bit of white and a little bit of pink. That's quite concerning. The other thing is the diameter. Overall, anything larger than a pencil eraser, which is 0.6 centimeters, should prompt some consideration for attention. And then the other incredibly important thing is evolution. In other words, changes in size, changes in shape, changes of color of any existing mole and or any other skin lesions. That is what we use every single day in the clinic when we evaluate our skin. But one thing that I want to add is one that I use likely the most when I examine patients in my own clinic, which is what we call the ugly duckling sign, right? Meaning that we all, as individuals, have what we call like a signature mole, right? When we start looking at our moles, we're like, oh yeah, they kind of like all look about the same, right? They kind of like all look like one another, right? You're like, oh yeah, they look like they all belong in the same family, right? That they are all related one way or the other. However, if there is a lesion on your skin that stands out to you, that you're like, you look weird, you look like you don't belong on my skin, that should be something that would be worth addressing with your primary care doctor and or with your dermatologist. And again, that is what we call the ugly duckling sign, which is a very important thing that we do when we do skin examinations. Okay, as I mentioned before, melanoma can appear in any surfaces, right? But in patients with skin of color, is going to be very commonly found on non-sun exposed skin, such as the bottom of the feet, the palms of the hands, the fingers, the toenails, the mouth, and again, underneath the nails. When we talk about non-melanoma skin cancers, we talk about the squamous cell carcinomas and the basal cell carcinomas. Squamous cell carcinomas are in fact the most common skin cancer in African American patients. What causes non-melanoma skin cancer? As I mentioned before, when we talk about UV radiation, that is without any question the primary cause of both squamous cell carcinoma and basal cell carcinomas on patients with lighter skin phenotypes. However, the most important predisposing factor for the development of squamous cell carcinoma, which is the most common skin cancer in African Americans, are things like chronic scarring, chronic trauma, chronic inflammation. Like what? Like, for example, burns, like, for example, non-healing leg ulcers, like, for example, scarring inflammatory process like skin lupus, all of which can be found in non-sun exposed areas. When we talk about melanoma and non-melanoma skin cancer, it's important to remember that, again, although darker skin does provide some protective effect, nonetheless, non-melanoma skin cancers are still going to be things that are going to see in our patient with skin of color. So how we identify non-melanoma skin cancers? When we talked about melanoma, we talked about those A, B, C, D, E's ugly duckling sign. When we talk about non-melanoma skin cancer, it's a little bit harder because they can look very different. But for the most part, things to keep in mind are that, number one, they might be asymptomatic. So if it looks funny, even if it's not giving you any trouble, ask your doctor. The other thing is that they can grow very slowly or they can grow rapidly. Ask your doctor. And anything that is painful, tender, or bleeding on its own, definitely ask your doctor, okay? As we talked about with squamous cell carcinoma, because these occur in non-exposed sites on those patients with darker skin types, keep an eye on the leg, keep an eye on the perianal area, keep an eye on the genitals, right? And again, keep an eye on anything that hurts, that is painful. When we talked about basal cell carcinomas, regardless of the race, keep an eye on the head, on the neck, keep an eye on anything that is shiny and that tends to bleed on its own. Oh, I thought it was a pimple, but every time that I get into the shower, it bleeds easily and it doesn't seem to heal. Seek a dermatologist, okay? One other thing that is important to keep in mind is the last sentence that I wrote here, that in people of color, about 50% of basal cell carcinomas, as opposed to only 5% of patients that are Caucasian, are going to have some color. So here are some examples of basal cell carcinoma in an African-American patient and in a Hispanic patient. Shiny, ulcerated, they bleed very easily. And here are some signs of squamous cell carcinoma in patients with skin of color. They are tender, they are painful. The one on the left side next to the lip grew very rapidly. The one on the right side is something on the leg. It's kind of like firm and scaly and very tender when it's touched. So how are we going to detect this type of skin cancer? Well, of course, you can see a dermatologist, but also remember that performing self-skin examinations are going to be an incredible good way of detecting skin cancer early. So it's important to examine your skin from head to toe, from front to back. So try to do that with a full length mirror. Try to look at your underarms, try to look at your forearms, try to look at your palms, right? Bend your elbows to make sure that you're looking at that, right? Look at your legs, look between your toes. And again, especially for patients which have darker skin types, very important to keep an eye on the soles of our feet to look at the spacing between our toes. And you can do that by sitting, of course, in a chair. The other thing that you can do is that you can use a handheld mirror. Handheld mirrors are going to allow you to examine the back of your neck, also your scalp, and you can also use a handheld mirror to examine areas such as your back and your buttock, okay? So as we have talked about, all of these skin cancers for the most part, right? Although we talked about how squamous cell carcinoma is a little bit of the exception of the rule, nonetheless are going to have a very important relationship with sun exposure. So why is it important, therefore, for people that have darker skin tones to use sunscreen? So why should we actually be doing this? Well, let's go again back to a little bit of our basic science. So let's talk a little bit about UV radiation. So as we have talked briefly before, UV rays are those rays that are going to be produced by the sun. They are going to include both the UVA and the UVB. And one thing that is important for you to keep in mind, right, as you can see in the picture on the right, is that UVA rays are going to not penetrate as deep. So usually they're going to be the ones that damage the epidermis, but UVA rays are going to penetrate much deeper. So not only they're going to damage the DNA of the cells, they are also going to damage the collagen and the elastic. So therefore, the UVA rays are the ones that are going to cause a lot of photoaging. What sunscreens are going to do is they're going to reflect up those rays, and they are not going to allow, therefore, for the sun the sun rays to penetrate through our skin. So one thing that is an incredibly big misconception is that Black skin don't crack, correct? We have all heard this before. Is this actually right? Like, is this correct? Well, it is not, right? Skin is skin, and Black people can get sunburn too. So again, although melanin might protect against a small percentage of the UV rays, Black people are still susceptible to sun damage, such as sunburn, such as melanoma, again, hyperpigmentation, fine lines, and premature aging. This all comes from something that is called the Fitzpatrick skin types, this misconception, which usually classifies skin types, medically speaking, on type 1, type 2, type 3, type 4, type 5, and type 6, where we're talking about the reactivity to the sun. So for example, patients on the left side quarter of the spectrum are patients that are always going to burn and are never going to tan. So then the people that developed this skin this kind of like rule, right, thought that then therefore, right, the end of the spectrum toward the right should be a skin that never burns. But is that actually correct? And the answer is no. Yes, patients with darker skin phenotypes might tan very easily, might have deeply pigmented skin, but they can still burn. Skin is skin, and skin burns. So why should people, therefore, with skin of color use sunscreen? Again, because it's a terrible myth that individuals of color do not require the use of sunscreen, or that do not require much sunscreen as fair-skinned individuals. While we know that skin color does not tan easily, does not burn easily, we know that the damage caused by UV rays still occurs on sun exposures and sun-exposed sites. We also know, as we have discussed before, that unfortunately, individuals with skin of color are going to have more serious consequences when we talk about skin cancer than Caucasians. And again, we all know the magic of melanin, and it's a wonderful thing that we should embrace and that we should celebrate. But it's important to not overestimate when it comes to the power of sun protection, right? So some dermatologists that specialize in skin of color, they have calculated that maybe patients with dark skin type have an SPF, and I'll go into that, of about an SPF of 13. But when it comes again to the sun damaging effects, then that SPF of 13 that some Black people might have in some areas of their body are definitely less than the daily use of an SPF of 30 that we are usually going to recommend as dermatologists for sun protection. So let's get a little bit deeper into sun protection. So what do then a sunscreen is going to do? So as I showed on that previous picture, right, what sunscreens are going to do is that they are going to absorb harmful UVA and UVB rays. And therefore, because of that, the regular use of sunscreen without any question can help prevent skin disorders, including the development of skin cancer. UV protection is key for protecting oneself from skin damage. Sunscreens are going to be categorized depending on their SPF number. SPF stands for sun protection factor. So with so many SPF numbers, which one should we choose for? The Skin of Color Society, which I'm quoting here on our slide, for the most part is going to recommend using a sunscreen with an SPF of about 30. That is also broad spectrum, very important. It needs to protect against both UVA and UVB. So it needs to say that on the label, broad spectrum, or UVA and UVB. What does the SPF actually stands for? Well, what it actually stands for is that if normally, let's say that your skin takes about 10 minutes to get red with sun exposure, when you add an SPF of 15 or an SPF of 30, let's say, then it will mean that you will be able to delay that sunburn by 30 times. So in other words, it's going to take 30 times as longer for you to get the same amount of redness. So that, however, is in theory, not in practice. And the reason for that is because sunscreen wears off with perspiration, with water. None of us apply enough sunscreen. None of us reapply it frequently enough. So again, this is more theoretical than real. Another thing that is important to keep in mind, and I just want to make sure that I quote the source of these beautiful pictures. These pictures come from Healthline, from a paper written by Tiffany Oneyakawa about sun protection in skin of color. So again, I want to definitely credit those beautiful infographics, this one and another one that I'll show later. So one thing to keep in mind is that unfortunately, cosmetic companies have traditionally marketed sun protection to patients with white skin. So unfortunately, that very likely has contributed to the lack of more widespread use among people with skin of color. However, fourthly, some companies are starting to become more attuned to the cosmetic needs of Black people, including using also some protection that is going to be more cosmetically elegant for patients with skin of color. In other words, skin products that are not going to leave a white residue or a white cast that is going to make the skin look very great after application. In addition to sun protection, it's important to also keep in mind that sunscreen is not the only thing that is going to protect ourselves from the sun. Make sure that you're not going to tanning beds. Try to seek the shade, especially during the high peaks of sun exposure, including like 10 a.m. to 12 to maybe around 2 p.m., right? Get vitamin D safely. Our skin is definitely one way of getting vitamin E. However, it's important to know that we can definitely also ingest vitamin D very safely. And that's another thing that is important to talk about with your dermatologist or with your primary care doctor. Use your sunscreen. Be cautious about any reflection. We live in Michigan, and in Michigan, we have a lot of snow, and that snow is going to reflect all the light up. Therefore, you need to use your sunscreen year round. And again, don't underestimate protective clothing, including a wide brim hat, sunglasses, and some protective clothing. So then based on the above, when should someone visit a dermatologist? Well, going back to what we talked for skin cancers, right? If you have any lesions that are painful, that are bleeding, that are growing, that are changing, or is in any way, shape, or form concerning to you, it should be evaluated by a dermatologist. Unfortunately, however, it's important for people to be aware that there are certain group of people that are less likely to seek the care of a dermatologist. That includes Blacks and Hispanics, that includes men, and that includes patients with Medicare and Medicare, okay? So it's important for us to start breaking and filling that gap. So what do I do as a dermatologist? Well, dermatology is a fascinating branch of medicine that deals, as I mentioned before, with skin, with hair, and with the nails. There's about 1,500 different skin types that have many different variants. It's important for you to know that me as a dermatologist, I'm not the only one dealing with skin. About 1/4 of all, in other words, like a quarter of all visits to primary care are going to involve some sort of complaint that is going to involve the skin, the hair of the nails. Between 50 and 75% of individuals at any given time might be actually experiencing some sort of skin disorder. And although some skin conditions tend to be relatively harmless, let's say warts, let's say dandruff, let's say insect bites, many skin disorders can result in significant disability. Another thing that is very unique about skin and skin disorders is the impact that it's going to have on our well-being. Most dermatological conditions are going to be highly visible. And because of that, they may unfortunately invoke self-consciousness that can have a very profound negative psychosocial effect on the patients that have it. It can result in negative self-perception. It can result in depression, social rejection, and social isolation. People with unfortunately skin disorders can be subject to emotional abuse, verbal abuse, and bullying. So it's important to know that, again, our patients that have skin diseases, even when they are skin deep, they can suffer deeply. I just want to finish this by talking a little bit again about the impact of our skin and encourage us to embrace this incredibly important concept that beauty has no skin tone, right? Humans are a very diverse set of individuals that comes in all sorts of beautiful shades, and is very important for us to embrace our own skin, to shine with our own brightness, and to encourage others to do so as well. It is also important to push for that to continue to happen. One example that I just wanted to bring up is this, for example, is Unilever, which, as you might know, is one of the largest manufacturers of personal care products out there. And Unilever is finally, right, renaming this Fair and Lovely skin cream, after a tremendous backlash. Why? Right? Because unfortunately, these skin lightening creams, have been criticized as promoting negative stereotypes around dark skin tones. So unfortunately, those negative stereotypes come from the industry, but they also come within ourselves. So it's important, again, to embrace our own glow and embrace our own beauty. There's a lot of work to be done. There's a lot of closing gaps that need to happen. One thing that myself as an academic dermatologist, I'm trying tirelessly to do is to increase the specialized knowledge about treating skin of color. We know that our textbooks, we know that our magazines, we know that our journals don't have enough representation of skin of color. We are trying diligently to make sure that we are adding different skin disorders of different presentations on different patients, on different skin colors in everything that we teach our residents. We're also trying to do our best to increase our number of Black dermatologists. There is definitely, without any question, a race concordance when it talks about patients' comfort to seeing physicians, including dermatologists, when those physicians are from the same race or from the same ethnicity. And then again, we should push companies to become more attuned to the needs of Black people. So it's 12:20. So I just want to thank everyone for your time and for your attention. And I am open for any questions that I'll do all my best to answer.
All right, I have a couple questions here. So this question comes from Betty. She asked this a little bit earlier in your presentation, so she may have got some more information, but I want to ask it again.
Of course.
So with aging, I believe my cheeks are getting more and more dark spots and I'm losing more and more hair. I'm growing hair everywhere but on my head. What did I do? Or what should I do?
Yes. So unfortunately, yes, that is something that we're going to see as a phenomenon of aging, right? We're going to see a decrease on hair growth, for example, on our scalps, and we're going to see an increased hair growth on other parts of our body. That might be something that might be a little bit more difficult to deal with, right? Because you might need some either prescription and or non-prescription recommendations for hair growth. There are some pretty safe and pretty efficient hair growth products that you can try over the counter that you can discuss with your primary care doctor and or your dermatologist. In terms of the increased amount of sun marks or sunspots or dark spots, those are likely related to sun exposure, to again, cumulative to sun exposure, which I missed to say. I think that some people think, well, whatever, all the damage is done, right? At this point in life, I should just not be even bothering on using sun protection. That is not true. Sun damage is cumulative. So again, it's always a good time to start wearing sun protection. So if any of the skin lesions are specifically concerning, please do seek care. Otherwise, try to go ahead and up your regimen in terms of your sun protection.
Excellent. And a reminder to everybody who's still on, if you have any more questions, please pop them into the chat or the Q&A box, and we'll pass the questions along. So here's another question from Brenda. Is there any benefit to taking the CoQ10 collagen tabs?
Brenda, that is a really tough question. So CoQ10 is an antioxidant, right? It's a known antioxidant. So does it have a positive effect on the skin? The answer is possibly, right? In the sense that, we do know that antioxidants, for example, when they are applied to the skin, they can help protect us from sun exposure, from sun damage, and they can also help, again, with the regeneration of collagen. So products that we put on our skin that are antioxidants are going to have definitely a positive benefit on our skin. Taking enzyme Q10 by mouth has been less studied, but I would say the answer is possible. Collagen is even a harder question to answer because, again, collagen is such an important piece of our skin that therefore trying to replenish it is at the top of everyone's priority. The answer is that when we have done the studies about collagen, and by we, I should mean them, other smarter dermatologists, right? They have actually realized that collagen is a very large molecule. Therefore, it almost doesn't get absorbed in our GI tract, in other words, in our stomach and in our intestines. So they don't really know how on earth it will help. But in some very, 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 very extremely small studies, it seems like maybe it helps. So again, there's this confounding and very confusing evidence where in one hand, we don't know how on earth is it possible for it to help, but on the other hand, we have some incredibly small studies that show that it might help. So basically, stay tuned, more info to come.
Good. All right, Lula asked a pretty straightforward question. What is a good sunscreen?
Okay, Lula, good. A good sunscreen is going to be a sunscreen that is going to be broad spectrum, as we mentioned before, that has an SPF of 30 or above, right? And sunscreen that is broad spectrum, in other words, UVA, UVB, and again, an SPF of 30 or above. And then unfortunately, Lula, it's likely going to require a lot of trial and error because the best sunscreen is the one that you're going to use. And therefore, it might require trial and error to find one that you like. I personally like tinted sunscreens. Tinted sunscreens are those sunscreens that when you squeeze out, they give you a little bit of color. That is good for patients like ourselves that have skin of color. They kind of like, again, make that white residue not as prominent. They also blend very easily and they are very good in terms of sun protection. So trial and error. Please do know that you don't need to invest in super fancy brands that you need to buy on, high-end stores. Brands that you can find in regular retailers are perfectly adequate as long as you look for those. Broad spectrum, SPF of 30 or above. Look into tint that you might like that.
All right, very good. Cynthia asked a question here. Are there any specific areas of concern that apply to diabetics?
Yes, when it comes to diabetics, there's going to be multiple areas of concern, but one of the main areas of concern is going to be your feet and your legs. So again, as you all remember, right, unfortunately, one of the manifestations that we have on patients that are diabetics is that the nerve endings, right, including the nerve endings that go to our skin, are not working as well, right? So those nerve endings that don't work as well is what we call neuropathy. So when somebody has neuropathy, then unfortunately, they might not feel when they have a little stone on their shoe. They might be a little bit less prone to feeling trauma or things like that. So when it comes to the skin care of patients with diabetes, it's exceedingly important for them to keep an eye on their feet. Examine your feet, make sure that there's no little thorns, make sure that there's no little bruises, make sure that there's no, let's say like blisters or anything like that, and moisturize.
All right, two more quick questions, and I think we'll wrap it up and go on to our wrap up here. So Tommy asked, what are skin tags? What causes them? And can anything be done to prevent or stop them?
Oh, damn, yeah, I'm so sorry. That is $1 million question and the one that is going to allow me to retire whenever I can find, the treatment for skin tags. But while we cannot retire, what we know about skin tags is that they are completely benign, meaning not cancerous, meaning they will never become skin cancers, overgrowth of skin. And they are exactly what they sound like, basically like little overgrowths that are like little pedunculated spots of skin. What causes them? They are caused by aging, they are caused by genetics, and they are caused by friction. So we cannot avoid birthdays, and we like birthdays. We cannot change our genetics, but we can improve friction. So friction meaning rubbing of clothing with skin, meaning friction of rubbing of skin, and skin is usually secondary to overweight or obesity. And that is something that you can try to do. So try to reduce friction as much as possible. And then you can always have them treated for cosmetic concerns or if they are bothersome to you.
Okay. Very quickly, Rose asks, what is the treatment for vitiligo?
Ooh, vitiligo is a condition that is exceedingly difficult to treat, but nonetheless, that can be treated. And the reason why I say exceedingly difficult to treat is because it takes time, and it takes discipline, and it takes a lot of like approach from both the physician and the patients. So you can treat it with multiple different ways. You can treat it with anti-inflammatory medications. Why? Because again, you can basically ask those immune cells that are attacking those melanin-producing cells to shy away by putting medications that reduce inflammation. So that is one of the main ways that we treat vitiligo. We can also treat vitiligo by actually exposing patients to a very specific type of ultraviolet light. So not white broad spectrum sun exposure, but actually what we call narrowband UVB, which are something that can be done in your dermatologist's office. And then there are some also very interesting emerging therapies for treatment of vitiligo.
All right, and real quick, one last question. Can squamous cell cancer come from wearing makeup? Also, I have a patch lesion on the lower right of my face that is bigger than a pencil eraser.
Okay, so can skin cancer come from makeup? The answer is likely not. And the reason for that is because of the type of ingredients that are going to be present in makeup. Are there some ingredients that are a little bit more dangerous? Yes, they might be. However, usually those are going to be things that are not going to be regulated by the FDA. In other words, products that are being imported from other countries that have higher quantities of ingredients that should not be on personal care products. But for most regular personal care products, I would say no. The risk of skin cancer is likely zero. If it stands out to you tremendously, if it's changing, if it's painful, if it's tender, if it's bleeding, please seek medical care.
All right. Thank you so much, Dr. Castanedo Tardan. That was a wonderful, very exciting presentation, full of energy and full of great information. So Vanessa, let's pass it off to you, and we'll take care of our last orders of business and let everybody carry on with their day. Thank you again so much for your time.
Yes, thank you for such an amazing presentation. We just want to quickly share our program that we're starting. Sean, if you don't mind showing that flyer. And so we would, before we end and let everyone go, we just want to share this new program HBEC will be starting. And our Master of Social Work intern student, Hannah, is going to share more on this for us.
Is the worst one. Okay, can you guys hear me okay?
Yes.
Awesome. So I'm just gonna talk a little bit about our program. So basically we named it Party Line because we wanted it to be kind of a social group, just a way to have older adults interact with each other. We do have some topics laid out, but it's not meant to be overly structured. It's meant to be something that if we need that backup topic for the week, we can do that. And if it's something that interests all the members of the group for that week, that is awesome and we can work off of that. But if the older adults have something that is really pressing that they want to talk about and that they think would be valuable to share with others, I think that will be great as well. So basically to join us, since it's a virtual program, it is either over the computer like we are today or on Zoom, or over the phone. So you guys, if you need anything, if you have any questions, you can always email me or the other MSW intern, and her name is Sarah. And so our email addresses are both wayne.edu. Hers is ER7366, and I can put this in the chat, and then mine is FC8926. Or you could just call the Healthier Black Elders line and one of us will get back to you. I think that's about it. I know Tam said earlier when we were having our meetings, so our first one is coming up December 5th, and that's at 1 p.m. And we're both really excited about it. And then we'll have a mini break and then come back in January and go until April. And I'm very excited to hear from everybody.
So just to clarify, it's December 15th?
15th, yes.
And second of all, for those of you who want to Zoom, there is a way to Zoom in. So why don't, I think one way to do it is call the HBCE office. So I'll just say the number for everyone in case you forget the number out there. 313-664-2616, and one of the interns will get back to you. So you can also call Vanessa about it because everyone knows Vanessa, and you'll find out more. But we hope to see you. I will be there next Tuesday at 1 p.m. I'm excited to see what we can do before the holidays, see if we can get the social group going. And I just wish everyone a great afternoon. Thanks, Hannah, for organizing. Thanks to Sean and Vanessa and Dr. Tardan for all the great work for today's program. The social group for older Detroiters is share as widely as you like. We want to, anyone, anywhere, we're going to start circulating flyers to many, many community agencies. So thank you.
Perfect. Thank you so much. And just so everyone knows, today's presentation has been recorded. So we will be uploading all of our Lunch and Learn recordings to our website at the end of this month. And lastly, if there's anyone with us that's not currently a member of the Healthier Black Elder Center program and would like to join, we can sign you up over the telephone. If you'd like to just give us a call at that 313-664-2616 number. And when you become a member with us, you'll receive our biannual newsletter, you'll learn about research studies, and you'll learn about future programs like this one today. So thanks again to everyone. Please stay safe and have a very happy holiday and New Year.